everyone, myself Dr. Priyanka and I'm one of your mentors for study MRCPI. So today we are back with the OMR series and we will be discussing an important OSCE oriented exam station which is on the multiple pregnancy structure discussion. So do like, share and subscribe Study Medic channel and also press the bell button icon to get the updates on recently added videos. So always remember that success is focusing the full power of all you are and on what you have a burning desire to achieve. So this is a structured discussion task actually, which is on the multiple pregnancy, the monochronic twin pregnancy, and Dr. Soumya will be my examiner and I will be the candidate. Thank you, Dr. Soumya, for joining.
Thank you, darling. Yes, just a minute. Let me keep a timer. Yes, you can start.
Hello, I'm Priyanka and I'm one of the exam candidates. I have read the scenario and I'm ready for the discussion.
Okay. Fine. So you have gone through the scenario. Can you please summarize the case for me?
Yes. So, so my patient is Mrs. Sadia Mustafa, who is 26 years old, and she is with the, according to the image that I can see, she is with the case of a multiple pregnancy, probably a monochorionic amniotic twin pregnancy with 12 weeks of gestation, and has come for her antenatal management.
Okay. Before proceeding to the further management, what additional information you would want to gather from her?
Yeah. So here, I want to make her first comfortable, and then I would like to confirm her name and age first, and also would like to check the same name and age on the report. Then I would like to ask a few questions, considering the is it her first pregnancy, and also the type of conception. Is it a spontaneous or an IVF pregnancy? And any complaints is she having? Like as she has a multiple pregnancy, so if there is any excess nausea or vomiting, or if there is any bleeding or spotting PB, that I want to ask. Then other is the are her cycles, were her cycles regular, previous cycles, and had she used any contraception before her cervical smear history, as she is 26 years old, so she must have received one invitation. Then I would like to ask her about any medical history, especially any history of diabetes or blood pressure, any asthma in her or in the family members, and any surgery she had, especially on her pelvis, and any family history of twin pregnancy I want to know, and other medical history in the family. Also, any admissions for any nausea or vomiting I want to know in her, and what medication she is on right now. Then any allergies if she has, and what is her blood group, and is she does she have any reservations for blood transfusion, and her BMI also I want to know, and the psychological history, and how is the support at home. That is very important in case of multiple pregnancy.
Okay, so this is a case of IVF pregnancy because they tried for almost last 4 years and she didn't conceive. It's an unexplained infertility. So actually, she is not allergic to any medications. She is generally fit and fine, no family history of comorbidities. Her BMI is around 23. So based on this information, so how would you plan her for the care of antenatal further plans?
So now the only her type of pregnancy is IVF conception. So here I want to know it's a donor twin, it's a donor or a self egg, and then as she's 12 weeks right now, so and the NT scan, this is an NT scan which is already being done. So here I would like to offer her a combined screening, that is with a dual marker test, which will give the risk of having the Down syndrome, Turner's, and the Patau and the Edwards syndrome. And along with that, I would like to start her on the low dose aspirin because of the risk of multiple pregnancy, like preeclampsia and even fetal growth restrictions. So I would like to start her on aspirin. And then I would like to call her, and also I will make sure that she has taken high dose of folic acid. Then later I will call her for the detailed anomaly scan. And as she's a case of a monochorionic twin pregnancy, so her scan schedule will be every 2 weeks from 16 weeks because of the risks of TTTS and TRAP, and also selective fetal growth restriction, which and also birth defects, which is quite more in monochorionic twins. And a fetal echo, I will arrange her between 22 to 24 weeks.
Okay.
Then,
yeah. So just to ask you, like, what are the problems you can encounter during antenatal care of these monochorionic twins?
Yes. First of all, multiple pregnancy is a high carries high risk than a singleton. From the first trimester starting, there can be increased risk of miscarriage, increased risk of having abnormalities, congenital abnormalities in the baby. Followed by the combined screening that is usually has a good sensitivity in singletons. The sensitivity is quite reduced in twin pregnancies. Then followed by that, there is increased risk of if it is monochronic, it is the TTTS or a twin reverse arterial perfusion or a single fetal growth restriction. Also, the risk of single fetal IUD is also more in case of monochronic twins. And also at the in the third trimester, there can be abnormal Dopplers that can happen if it is complicated by TTTS, and hence it increases the risk of cesarean sections, abruption, placenta previa, and also intrapartum increased risk of PPH.
Okay. No problem. So, can I move to the next slide? Because at 22 weeks, she got a scan done. Okay. And the estimated fetal difference is 30%. And you can have a look in the Dopplers of both the twins and give me what's your diagnosis first.
Yes. So according to the Quintura staging, she falls into stage three of the Quintura stage, because here there is the fetal growth restriction is there, a difference is there of almost more than 18, that is 30% it is there. And also there is Doppler changes, that is in the there is in the donor twin, there is almost reverse and diastolic flow that I can see in the umbilical artery Doppler, and also reverse ductus venosus flow in the recipient twin, which are the morbid changes which you can see in the stage 3 of the Quinteros stage. Along with, there will be a oligohydramnios in the donor twin and a polyhydramnios in the recipient twin, and fetal growth difference will be there. The fetal weight of the donor will be less.
Okay. So now, according to the stage, how we are going to manage this patient?
So now she is 32 weeks. So here it will be the role of the multidisciplinary team, which will be by the my consultant, and especially the fetal medicine specialist, who will be, because the management in this case, the first line preferred is the fetal laser photocoagulation. That is the laser ablation of the anastomotic vessels, which is usually done less than 26 weeks, and it is done by the fetal medicine specialist. So they will be involved, also the anesthesiologist, and that will be the management in this case.
Okay, so what further complications you expect, and what is the intrapartum care you would want to keep for her, and what is your timing of deliveries and all that based specifically for this this patient?
So here, if she now she is undergoing TTTS, the laser ablation. So the reanastomosis can happen in almost 14% of the cases. That is the failure rate. But if it is successful, then she can deliver if it is, because it's a complicated multiple pregnancy because of TTTS. She needs to be delivered by 34 weeks. Otherwise, the monochronic twin pregnancies without any complications like TTTS or TRAP, they can be delivered by 37 weeks according to the Irish guideline, and the dichronic twins by 38 weeks. So earlier, if the TTTS management has failed, as I said, in case of 14%, there can be reanastomosis and failure of the laser ablation, in which case she needs to be delivered like before 34 weeks.
What is the mode of delivery? If if everything is going well post laser ablation, so what is the mode of delivery you would want to do? And take me through a intrapartum risk and the postpartum management as well.
So if the laser ablation goes well, so it again depends upon multiple factors, like how is the first twin presenting. So she can have a vaginal delivery if the first twin is cephalic, and is in the cephalic presentation. Also, for the second twin spec, that is the donor twin, if it is a reverse end-diastolic flow in that twin, so the patient needs to be counseled the estimated fetal weight during that time, and the viability should be taken into account. And then for the reverse end-diastolic flow part, then a cesarean section is recommended. But otherwise, she during the delivery, if she plans for the to have a vaginal delivery, then I will counsel her about the risk. Like during the intrapartum, there can be increased risk of having a operative or a cesarean delivery, increased risk of fetal distress, because it's a complicated by TTTS, and also there can be increased risk of postpartum hemorrhage also in her case.
Okay. What about the like postpartum few challenges with the mother with this twin scan?
Yeah. So, with the twin pregnancy, postpartum, as I said, the family support is very important in these cases in the postpartum period. Also, there they can have problems in the breastfeeding. The breast milk may be insufficient in these cases, so they should be well supported. And there can be increased risk of, as I said, postpartum hemorrhage in the postpartum period also. So, the multidisciplinary team role and also the family support comes role in this place.
Okay. I asked you extra questions because we had so much of time. I think you managed all of them well. I know it wasn't in the script, and because we had plenty of time, so that's why I had to go ahead. And I think you did fairly a very good job. For only thing when you go for the summarize, just cover a bit about your recommendations. Also, that was the only thing. And I think when you come for the management, of course, I think smears are even if you omit it's okay, but if you even if you say it's fine. And IVF, I thought when I explained about the management, you spoke about the donor twin. I think that is really not going to help unless it has
Mm.
got something with the older women and all that, no? And I
Yes.
think aspirin, growth scans, and the type of the twin which you picked up, and post management, all that was fine. Probably you could add postpartum, the lactation consultant specifically, if you could add preterm and all that. That's the only thing. Otherwise, it went all well.
Thank you, Dr.
Yeah.
Soumya. Yeah. So, coming to the station, so here history taking is very important in case of multiple pregnancy. The type of conception is important, specific points, and any previous pregnancies, any family history of multiple pregnancy, and especially past history, personal history, especially if she has any other medical conditions that which can also increase the complications. And any admissions if she has, like in case of multiple pregnancy, there is increased risk of hyperemesis and spotting also, so that also needs to be specifically asked. So what are the complications that are specific to monochorionic is the twin to twin transfusion syndrome, which happens in 15% of the cases, followed by twin reverse arterial perfusion, where the one twin is the cardiac twin, and a TAPS, that is a twin anemia polycythemia sequence, and a single fetal growth restriction, as also we saw in this case. So if the estimated fetal weight difference is more than 18 to 20%, we call it as SFGR, and there can be cord entanglement and increased risk of birth defects. So here we can see that there is a stage 3 Doppler changes, Quintero stage 3. So this is the Quintero staging. So there are 5 stages where this patient belong to stage 3. So knowing this staging is very important because the management depends upon that, and also what is the gestational age of the patient. So for her, the laser ablation of the anastomotic vessels is the mainstay of treatment. So now the maternal complications can be in the form of antenatal complications. There can be anemia, the preeclampsia, or other gestational diabetes. And intrapartum, there can be increased risk of abruption or increased risk of postpartum hemorrhage. Even then, they can have a preterm delivery. And also because the placenta is, there are in monochlorine, the placenta is large, so there can be placenta previa also. So here, how in the antenatal period is used by a multidisciplinary team. So it will be by the consultant, the fetal medicine specialist, anesthesiologist. During the time of delivery, there should be two neonatologists which will be present, the specialist midwife, and also the GP and the lactational consultant should be involved. And she had already the NT-NP scan, so she should be started on the low dose aspirin, and combined screening should be sent for her. And as it is a monochorionic twins, the scan schedule is every 2 weeks from 16 weeks onwards, and anomaly scan between 18 to 20 weeks. And here, the every 2 weeks scan, we need to check the deep vertical pocket in case of monochorionic twins to look for the signs of TTTS. Also, the fetal echo is suggested between 22 to 24 weeks. So what are the indications for referral to fetal medicine unit in case of multiple pregnancy? If it is a case of chorionic monoamniotic twins, that is Momo twins, if it is a case of TTTS, or one twin with anomaly, or one twin having IUFT, or if it is a case of single fetal growth restriction, or if it is a higher order, that is triplets and higher order pregnancies. So the timing of uncomplicated monochorionic twins is around 27 weeks according to Irish guideline, and the dichorionic twins it is 38 weeks. Whereas like in this case, it was complicated by TTTS, so the timing of delivery is 34 weeks. if it is TTTS was managed successfully, or before if any complication or failure of the laser happens. So intrapartum, it is by again a consultant-led delivery, and MDT. Here, continuous electronic fetal monitoring should be explained, which I forgot actually to tell. And also we have to watch for PPH and do active management of third stage of labor to prevent the risk of PPH and in the postpartum period. So breastfeeding is family support is very important. So she should be properly guided regarding the technique of breastfeeding, and also lactational consultant role comes here, and she should be provided with contraception, and the VT risk assessment should be done. So here a good candidate will ask about the mode of conception to know why the reason for the multiple pregnancy, any family history, or if it's an IVF conception, and any especially medical history, any complaints pertaining to multiple pregnancy if she has. And also the role of MTT is very important, asking about allergies, and here the any allergies, and the tackling with the monochronic complications is very important, and the timing of delivery according to the complications is very important. Thank you so much.